Hey, how's it going everyone? Nurse Brent here. Welcome back. Hope you guys are doing well. In my last video regarding travel ICU nurse Nicole Linton, we were left with two new details that could have contributed to the horrific multi-vehicle crash that happened earlier in August. One being her prior car accidents, and two, this undisclosed mental illness that she had. Now, with her hearing at the end of August being completed, more details have been brought to light. In this video, we're going to go over what happened in court, what this new detail is, and I'm going to teach you a little bit. On Tuesday, August 30th, Nicole Linton was back in court. This time it was for a bail review hearing. Her bail was set at $9 million. However, Superior Court Judge Miss Victoria Wilson postponed the hearing at the district attorney's request, citing for more time to seek additional documents regarding Linton's mental health issues or lapses in taking medication. Also, Linton's lawyers have not had adequate time for face-to-face interviews due to flooding at the facility. Linton will be held in jail for the time being without bail. The hearing is rescheduled for September 12th, and her arraignment is set for October 26th of this year. Now, I alluded to it earlier, but you know where this is going. We know as of last month about Linton's history of mental health, but now we have a diagnosis. It turns out she has bipolar disorder. She was diagnosed in May 2018 following hospitalization when she had a panic attack, ran out of her home, jumped on top of a police car, and was arrested for disorderly conduct. And it seems that this time around, it was an exacerbation of her illness. So during the time of the August crash this year, Dr. William Winter determined she had an apparent lapse of consciousness and could not remember the events leading up to the crash, but FaceTimed her sister naked before the crash happened. Her lawyer noted that mental incapacitation and unconsciousness are complete defenses to crime under California law. And this is true. It seems like they're going the route of pleading not guilty by reasons of insanity or possibly incompetent to stand trial if she does exhibit mental incapacitation. And that, my friends, is the new updates that came to light. Anyways, let's switch gears. Let's talk about bipolar, because Miss Linton does have a diagnosis of bipolar disorder. So bipolar is a mood disorder, usually emerges during early adulthood, but it can happen earlier. We see it sometimes in teenagers and also in children. For our pediatric population, we have to be very careful though, because manifestations of bipolar can mimic and mirror and are similar to ADHD. There are two sides to bipolar, hence the name. On one side, we have depression. The opposite side, we have mania. The depressive signs and symptoms are what you would expect from someone who is depressed. And I normally use the 5 A's to talk about the signs and symptoms of depression. Of course, these 5 A's do not encompass everything, for depression, but this is just a quick way for me to remember them. The first one is anergia. This is low energy, lack of energy. This is a person who does not have the energy to want to do things. The next one is going to be alogia. This is a patient who doesn't really say much. When you talk to them, you might get a couple of words, but they're not going to give you a full-blown paragraph about everything that's going on with them. The next A is anhedonia. This is the lack of pleasure in the things that they enjoy doing, that they like. They don't want to do it anymore. This one is extremely dangerous when it gets to the point where the patient starts writing that suicide note, or they start giving away things that have sentimental value, for no reason. When it gets to that point, this is a clear-cut sign that they might want to hurt themselves. Aside from that, we have avolition. This is the person who does not have the willingness, drive, or desire to want to do anything. It's that lack of motivation. Couple that with anergia. You have someone who doesn't have the desire to want to do anything, nor do they have the energy to do so. So they're not going to do anything. They're either going to sit in the chair all day, stay in bed all day, not really do much. And then the last one is affect. This has to deal with how the patient expresses their emotions. For our depressed patients, the affect that they're going to have is going to be a flat affect or a constricted affect. Usually most people have broad affect. Now, on the manic side, this is characterized by alterations in thought and bizarre behavior. And this is what Nicole Linton exhibited when she jumped on top of a police car in 2018. And this was also the behaviors that she was exhibiting prior to that multi-vehicle car crash, when she was FaceTiming her sister naked and she was driving recklessly. Right? Those are manifestations of manic behavior. On top of that, you may see elevated mood, restlessness, decreased sleep, rapid speech, impulsiveness, poor boundaries, racing thoughts, irritability, just to name a few. There are other signs as well. I usually tell my students to think of the Tasmanian devil, from the Looney Tunes. The character who spins around like they're in a tornado or a whirlwind, because this kind of is a great visualization of what a manic patient looks like in terms of behaviors. It can become very unpredictable on the unit when someone is exhibiting mania, and safety now becomes a priority because they can turn the unit hot. It can become very dangerous due to poor boundaries. They may get into people's faces. Now, they may not be aggressive, they may not be hostile, but because now they're invading someone's space, they're getting into rooms or parts of the hospital that they're not supposed to be getting into. Some patients might take offense to that and lash out against them because they're very high energy. They may be loud. Some patients may also take offense to that and try to strike out. So patient safety here, for the unit as a whole, is important. Now, there are 3 types of bipolar, and here's a very simplified chart of all 3 types. Bipolar 1 is having at least one manic episode alternating with major depression. This is the one that, compared to the other 3, is the highest acuity. In terms of severity, this is the most intense and may usually require hospitalization. Bipolar 2 is a step down. This is at least 1 to 2 hypomanic episodes. So hypomania is not full-blown mania, it's a little less severe, but there will be alternating major depression. Lastly, cyclothymic. This one is a patient or a person exhibiting over 2 years or so of hypomanic manifestations with alternating minor depressive episodes. So cyclothymic isn't as extreme, isn't as intense as bipolar 1 or bipolar 2. So now that we have a quick understanding of bipolar, well, let's talk about medications, okay? Just to let you know, Nicole Linton had stopped taking her medications during the pandemic. And this is the last thing, my friends, you want your patients to do. As we'll see in a bit, some medications used to treat bipolar have very narrow therapeutic ranges, while others take weeks to hit therapeutic levels and become effective. You're not supposed to go cold turkey on them. For my nursing students, remember to taper these medications if the patient is to stop taking them. Our job is to get the bipolar patient off the extremes, off from mania or depression, whichever side that they're on, and bring them to that happy medium, more so right in the middle of the so-called poles, and medication allows for this to happen. So, what medications can we give our bipolar patients? Well, there's normally 2 classes. It's the antiepileptic/anti-seizure medications and mood stabilizers. But before we get to those, I just want to talk about a few other medication classes that we can give. We can give anti-anxiety medications. We can also give antidepressant medications. Our first line for this will be our SSRIs, our serotonin, our selective serotonin reuptake inhibitors. Those work, those are great. We can also give other anti-anxiety medications, buspirone being one. We can also give our benzodiazepines, Klonopin, Ativan. Those work. You just have to be very careful about side effects for benzos, hypotension, and respiratory depression. And of course, for Ativan, we want to make sure that the patient is not using it for chronic use longer than 6 months. We can also give tricyclic antidepressants, not so much our MAUIs, because our monoamine oxidase inhibitors do interact with other medications. They're used rarely. So you may not want to jump to those right away. And of course, we can give antipsychotic medications. These medications do have mood stabilizing properties, but I normally don't run to these first until the patient starts exhibiting signs of psychosis like delusions or paranoia. But let's now talk about the two main classes, starting off with the antiepileptic or anti-seizure medications. These medications, of course, stabilize brain activity during seizures. And for the psych patient, it kind of does the exact same thing, for lack of a very rudimentary explanation that I'm giving here. But these medications are extremely versatile. This list includes valproic acid, which is Depakote, and carbamazepine. This is Tegretol. These are the two most common medications that I normally see. You do have other medications like Lamictal that you can give as well. Reminder though, however, to draw labs to check if the patient is at therapeutic level. We want to make sure that the patients are able to reap the benefits of these medications per se. So we need them over a certain threshold so that they can be stabilized. So for Depakote, for valproic acid, the range is normally 50 to 125, but most psychiatrists I work with want to keep the patient at around 100, give or take. And for Tegretol, carbamazepine, the range is 4 to 12. Now, we can talk about the big mood stabilizer. This is lithium carbonate, lithium for short. This is the one. This is the medication that people normally want to run and get when they have a patient who has bipolar, because this is a great mood stabilizer. It works well. However, it has a very narrow therapeutic range, very small, which means that toxicity, overdose is something that can happen, and I've seen it happen. Early signs of lithium toxicity starts and can go up to 1.5. We're looking at GI distress, nausea, vomiting, diarrhea, thirst, polyuria, patients peeing a lot, muscle weakness, fine hand tremors, slurred speech, and lethargy. From 1.5 to 2.0, we're looking at changes in level of consciousness and mental status, sedation, poor coordination, coarse tremors now rather than fine hand tremors, and of course ongoing GI distress, GI problems, nausea, vomiting, and diarrhea. Above 2.0, we're heading into that severe range. Everything, of course, that we talked about in terms of side effects, toxicity levels do play a role and come back again. But we're going to add on tinnitus, blurred vision, seizures, ataxia, hypotension, which can lead to coma and death. Once we're over 2.5, now we're looking at rapid decline in the patient's condition. They can die. This is fatal. Send the patient to ICU. Do not play around with this. So our therapeutic range, very small. It can pretty much start from the time the patient takes that first lithium pill all the way to 1.5 is when we're starting to see early signs, and then later signs as we get higher, to about that 2.5. The highest that I've seen was 3.2. I have no idea how the patient was standing, but we were able to get the patient to the medical floor, to ICU. She had been taking lithium for a very long time. So I think there could have been some tolerance that she built up to it just because of prolonged use. My friends, this is pretty much a short crash course on bipolar. I also wanted to give some of that updates about the court case that's going on. We're gonna have to see what happens on September 12th, what other new information shows up. Of course, I will continue to follow this. Take care, guys. I'll see you in the next video. Of course, if you have no comments, questions, concerns, or complaints that can be expressed in a therapeutically communicative manner, don't forget to like this video, subscribe to the channel, help me out. If you do have any questions, comments, concerns, complaints, comment section is down below. I'll see you all next time. Stay safe, stay cool, because California is in the middle of this heat wave. Catch you guys later. Peace.